Endometriosis. It is a condition in which there will be presence of functioning endometrium in sites other than uterine mucosa. Influence of cyclic hormones will stimulate the growth, but under the effect of continuous hormone, it will get suppressed. Now let's see the sites. It can be abdominal or extra-abdominal. The common sites involved are ovaries, pelvic peritoneum, pouch of Douglas, uterosacral ligaments, sigmoid colon, and fallopian tubes. And remote sites are umbilicus, abdominal scar, that is caesarean scar, episiotomy scar, lungs, ureter, kidney, and nasal mucosa. There are 4 theories included in pathogenesis of endometriosis. First is Sampson's theory, which is of retrograde menstruation. There will be retrograde flow of blood from uterine cavity to fallopian tubes, and then it enters peritoneum. Second theory, that is coelomic metaplasia, that was given by Mayer and Ivanov. It explains that due to chronic irritation of the pelvic peritoneum, the cell lining the pelvic organs will get converted into endometrial cells. The third theory is direct implantation. The cause can be iatrogenic. Common sites involved are abdominal scar following hysterectomy, C-section, tubectomy, or myomectomy. Episiotomy scar, vaginal or cervical site. Fourth theory, that is vascular and lymphatic theory, which was given by Halban. It explains that small amount of endometrial tissue will get disseminated through hematogenous and lymphatic spread. Now let's see the pathology of endometriosis. Endometrium, which is present at the ectopic sites, shows cyclic growth and shedding under the influence of hormones. After shedding, it will form cyst, and as the cyst gets larger, it will become tensed and ruptured, due to which it will lead to fibrosis and adhesions, and sometimes it may also form chocolate cyst. As it appears like a small black dots, it is called powder burns. It is seen on uterosacral ligament and pouch of Douglas. It will lead to fibrosis and scarring in the peritoneum. Now let's see clinical features. It is seen in age between 30 to 45. It can be asymptomatic. There will be lower abdominal pain and backache. There will be dysmenorrhea, means painful menses, dyspareunia, that is painful intercourse, menorrhagia, bleeding from surgical scars, vicarious menstruation, that is bleeding from sites other than uterus, infertility, urine frequency increases, and altered bowel habits. For diagnostic purpose, taking patient history is very important, like symptoms of dysmenorrhea, dyspareunia, altered bowel habits, urine frequency, bleeding from other sites. Then pelvic tenderness will be present, nodules in pouch of Douglas, and uterosacral ligament. On doing per speculum examination, we can see bluish spots in posterior fornix. USG is not so important. MRI, CT scan, and laparoscopy is a gold standard. Biopsy. Complications: rupture of chocolate cyst, infection, obstruction either intestinal or ureteral, In ureteral obstruction, it can lead to hydronephrosis and renal infection. Then malignancy. So rupture, infection, obstruction and malignancy. Next, it can lead to progesterone resistance. That will lead to luteinized unruptured follicle. So follicle will not get ruptured and ovulation will not occur. Now due to progesterone resistance, it will lead to corpus luteum insufficiency. Double LH peak will be seen. That means LH surge will be seen twice. If you want to understand it thoroughly, I have already uploaded shorts on double LH peak. Then elevated prolactin level can be seen. In treatment, preventive forcible pelvic examination should be avoided during or just after menses because endometrial tissue will be present during menses. So due to forcible pelvic examination, that will get implanted on other sites. In women with family history of endometriosis, not to delay the first conception. In curative, mostly patient comes with the complaint of pain and infertility. For pain, analgesics and hormonal therapy, GnRH analogs, danazol, combined estrogen and progesterone. IUCD releasing levonorgestrel can be inserted. Surgery, either conservative or definitive. For fertility, removal of endometrial tissue that improves the fertility of women and IVF.